Hello, everyone, and a warm welcome to today's edition of Patcast. Today is Tuesday, June 21st, 2022. I'm Rifat Mannan in California, and I'm remotely joined by my good friend Emilio Madrigal, who is in Boston. Today, we are very delighted to welcome back Professor Elizabeth Montgomery, who needs no introduction to those who are attending this lecture today. So Professor Montgomery is currently at University of Miami Miller School of Medicine, where she is professor of pathology. So today she is going to give a talk on one of her favorite GI pathology topics. And the title of her talk is going to be A Few GI Mesenchymal Lesions. And we are very lucky to have Dr. Montgomery online today. And thank you, Dr. Montgomery, for joining us. And as always, dear viewers, please feel free to post your questions or comments on YouTube and Facebook chat windows, and we will pass them on to Dr. Montgomery towards the end of the session. And over to you now, Dr. Montgomery. Thank you.
Okay, thanks a lot, Dr. Manan. It feels like yesterday that we were working together at Hopkins, but now we're remote. Okay, so let's enjoy a few mesenchymal lesions. Maybe I'll leave this here initially and then it will get in the way. So here we go. And let me put it up here. So what we're going to do is talk about my favorite thing, the layers in the GI tract in which various types of tumors often arise. And then, of course, talk about a few of the tumors themselves. And then end with a little commentary on some mucosal-based nerve sheath tumors. All right, so it's so important to realize that you can really be pretty far ahead on gastrointestinal mesenchymal tumors just by knowing what is found in which layer. So for example, inflammatory fibroid polyp that has PDGFRA, platelet-derived growth factor receptor alpha mutations, is almost always in the stomach. Sometimes it pushes out into the, submucosa pushes out into the muscularis propria, whereas GI stromal tumor, a subset of gastric ones which can have PDGFRA mutations, is generally housed in the muscularis propria. So let's do some little diagrams. I love to share these. This is obviously the gastroesophageal junctional area. Here's some stomach, here's some esophagus. The spindly things you might see here would be spindle cell melanoma. You might see leiomyomas, you might see granular cell tumors, and every so often you might see a gastrointestinal stromal tumor. Teeny tiny gastrointestinal stromal tumors are actually quite common in this area, but we seldom see them unless they're incidental findings. They're obviously not destined to progress. Okay, now we get into the stomach. We start to see mesenteric lesions in the stomach, but I'll focus on those as we go further. You still see your granular cell tumors in the stomach. They're up here. Inflammatory fibroid polyps are in the submucosa, and here are the suspects that we might see in the muscularis propria. We mostly see mesenteric lesions in the small bowel because that has the most mesentery. Remember, if you're taking your exams, gangliocytic paraganglioma can be quite spindly. And of course, we have some special tumors that live in the muscularis propria of the small bowel. And this used to be called clear cell sarcoma-like tumor. Now people like to call it gastrointestinal neuroectodermal tumor. But notice that lots of things start to crop up in the mesentery. We continue to see those mesenteric things in the colon, but something interesting happens. In the colon, we start to see all sorts of little mucosal nerve sheath tumors, and then frequently leiomyomas arise in association with the muscularis mucosae. So we're going to start with the mesentery. I'm going to move this little picture. And I'd like to talk a little bit about inflammatory myofibroblastic tumor. I'm older, so I remember before these were well described, and we talked about pulmonary inflammatory pseudotumors and plasma cell granulomas. And then we started to drill down and notice, oh gosh, similar tumors can be found pretty much anywhere in the body, but they were first noted in the abdomen and retroperitoneal areas. So this is such a case. I didn't put a ruler, but it was a giant lesional or giant sarcoma-like thing that was in the mesentery. And here's another such example, and let's look at our layers. So you can see the muscularis propria is fine here. This is gastric mucosa, submucosa, and here's this lesion that's extending from out into the muscularis propria. And this is actually another one that curiously involves all the layers, and this is a weird site for it. It's the gallbladder, but it probably started out here and then worked its way into the muscularis propria. And then, of course, the gallbladder has no submucosa, so it's even present in the mucosa. So pretty cute case. So this is how inflammatory myofibroblastic tumor looks at high magnification. This is a super high magnification image. You have these beautiful cells that have macronucleoli. These are the lesional cells. They're myofibroblasts. They often stain with actin, and they have sort of amphiphilic cytoplasm. In other words, they can't decide if they want to be muscle or if they want to be fibrous or fibroblastic cells. And notice that the backdrop is mostly plasmacytes and lymphocytes in this case. Sometimes you'll see a few eosinophils. It was quite some time ago, actually, that the whole ALK story got elucidated in inflammatory myofibroblastic tumor. And in 1999, Connie Griffin, who has passed away but was at Johns Hopkins, I don't think Dr. Menon overlapped with her. I think she'd already passed away. But she noticed that 3 inflammatory myofibroblastic tumors had rearrangements at the ALK gene, in other words, 2p23. And over time, ALK was shown to be rearranged with quite a few partners in inflammatory myofibroblastic tumors all over the body. And I've listed some of the known partners, and of course, there are others. Okay, so this is a nice fish preparation. You can see the normal gene pair here, and then you can see the rearrangement at 2p23 using these probes that are affixed to either side of the break point. And you can see that nice spindle cell nucleus in this ALK rearranged IMT. All right, but of course, it's a lot easier in most labs to do immunohistochemistry because it's more readily available. And this is a beautiful example of strongly positive ALK immunostaining and that gallbladder IMT that I showed you just a bit ago. So a beautiful preparation. And as a pitfall, do remember that quite a large percentage of inflammatory myofibroblastic tumors express keratin, which some people attribute to their submesothelial typical location. And this example is no exception. Of course, nowadays, the cool thing about the ALK rearrangement is that it's targetable. And crizotinib was the first target, or not target, but drug against the ALK target. And it's the good thing about it is you can take it by mouth. And the nicer thing about it is it reacts against several receptor tyrosine kinases. And of course, it was initially used in lung cancer. Only about 5% of lung cancers have ALK rearrangements, but lung cancer is so common that 5% of a big number still helps a lot of people. And now there are newer agents. It wasn't until 2010 that it was shown that you could use these things against IMTs that were aggressive. And of course, there are newer agents that do the same job for patients who become refractory to crizotinib. That would be ceritinib and alectinib. Of course, with IMT, the good news, if you're unlucky enough to have an aggressive one, if your tumor doesn't have an ALK rearrangement, it might have a ROS1 rearrangement, especially if you're a child. And nowadays, some of the IMTs have been shown to have NTRK rearrangements, and all of these molecules are targetable. All right, there's a high-grade form of IMT that was first noticed in 2013 by Jason Hornick and his colleagues. And they used a different term, but they're basically just high-grade IMTs. And he called them epithelioid inflammatory myofibroblastic sarcoma. Yours truly has misdiagnosed these as epithelioid leiomyosarcoma in the past because they tend to have pretty strong Desmond expression. And they can have really weird ALK immunolabeling. These do respond to the same targeted therapy, but unfortunately the patient has a honeymoon and then the response stops and eventually these kill the patient. So here's how they look. You can see we're in the mesentery of the colon, but the lesion, actually you can't see that. You can see that the lesion has extended all the way to the submucosa and looks very monotonous and far less inflammatory than classic IMT. At high magnification, you'll notice two things: macronucleoli, and I've tried to show you a neutrophil here. These tend to have neutrophils. Of course, if you just get something that looks like this, it could be anything, and you'll find yourself evaluating it for melanoma and carcinoma. You could get fooled by some focal keratin in these. And then eventually you'll think of, oh my gosh, could it be one of these epithelioid inflammatory myofibroblastic sarcomas? So if you do ALK, you'll get weird staining in many of them. So this is that same colon one. And when we go to high magnification, you can see that there's this sort of nuclear membrane area distribution of the staining extending slightly into the cytoplasm. And in all likelihood, this lesion has a rearrangement with RRBP1, and that particular gene or protein happens to live right on the nuclear membrane. So that's where you see the deposition of the staining. This is another such tumor that I had on a needle biopsy, and this is showing sort of the typical appearance of these with a fair number of neutrophils in the background. Curiously, the nucleus to cytoplasm ratio isn't all that high in these. And of course, the macronucleoli will make you think about other types of tumors before you come around to the interpretation. This one also has an unusual pattern of ALK staining. It's more perinuclear, and I apologize that the preparation's a little bit overstained. All right, the point of it is think of these things because they're targetable. I'd like to present a small aside, and that's IgG4 related disease, because we're talking about inflammatory lesions. It still is poorly understood. It's steroid responsive, and it has tremendous overlap with other immune diseases. The trouble is that if you get a small biopsy and are asked to do IgG4 staining, you can find it in association with other conditions that are malignant or infections. So do insist on good histologic criteria before you give your colleague a license to manage the patient with steroids. All right, so I know when I was training, I was taught about all these different diseases: Riedel's struma, these orbital pseudotumors, sialadenitis, the Kuttner tumor, retroperitoneal fibrosis, and so on, and of course, autoimmune pancreatitis. And really, those are all under the umbrella of IgG4-related sclerosing disorders. Sclerosing mesenteritis, on the other hand, is different, even though it can have occasional IgG, or it can have a lot of IgG4 positive cells. The important thing is that inflammatory myofibroblastic tumors can also feature a lot of IgG4 positive cells if you're asked to do it, or don't realize what you're dealing with and do it, but it's not steroid responsive. So it's a garden path you don't want to go down. So here's a nice example of IgG4 related fibroinflammatory disease. And this is that storiform fibrosis that you'll read about. Notice the kind of dense collagen, and there's a fairly dense inflammatory backdrop. And of course, the thing you want to look for to confirm your interpretation is obliterative phlebitis, which I find hard to spot. But the trick is to find yourself an artery. So let's see, here's the pointer. Here's a nice artery, and then, then you notice that, oh gosh, there's a structure next to it that's destroyed, and that's a vein with obliterative phlebitis. So this is another example, and you can see I've done a MOVAT stain, but if you don't have the MOVAT stain, an elastic stain works well, and it can help you identify these destroyed veins, because it's easy to spot the arteries, and then you look for the company they keep. What causes IgG4 disease? Well, I feel like we still don't know. Obviously, it's some peculiar immune condition. The trigger has really not been elucidated, There have been a couple of papers in very important journals touting various antigens. The earlier one in the New England Journal touted H. pylori, and a more recent one touted laminin 511, which is something we all have all over our bodies, so it's not really clear how the antigen becomes exposed in some people and not others. The important thing is if you're doing IgG4 stains, do remember that lymphomas can have a lot of IgG4 positive cells, and quite a few other immunologic things can have them. And that's all fine, but obviously you don't want to get a parasitic infestation treated with steroids. Of course, if I'm not a hematopathologist, but there are some lymphomas that do seem to arise in association with IgG4 related sclerosing disease. They tend to be mucosa associated lymphoid tissue lymphomas. All right, we're switching gears now. We're still in the mesentery. We have a big mass from the mesentery of a young gal. And here it is. Looks, well, like a great big sarcoma or smooth muscle tumor. Here it is at low magnification. It started in the mesentery of the small bowel. You can see small bowel mucosa on the surface. And unfortunately, the lesion is probably a little less bright pink than this, but you'll have to forgive me. Here's a better coloration. You can see your internal control for smooth muscle, this little tiny vessel, and it's not quite as, or it's more brightly pink than the surrounding lesion, and also really pops out at you. And here's a kit. So hopefully you're all thinking of a good diagnosis. And it's a mesenteric fibromatosis. So the kit is a tease. And of course, mesenteric fibromatosis can be a component of familial adenomatous polyposis, and virtually all familial fibromatoses have associated APC gene mutations, but the rest of them have mutations in CTNNB1, which is of course the gene that encodes for beta-catenin. So they're common. If you're in a big city, you will see them, 2 to 4 individuals per million per year. In children, there's gender parity, but then as soon as women start to have a lot of estrogen around, there's a female predominance. And they tend to be in the abdominal wall. Hopefully all of you know that. And if you're a resident, don't forget that. And of course, these have estrogen receptors. And then once women get older, then there's gender parity again. So what are the histologic features? Long fascicles of fibroblasts and myofibroblasts. I'm sure you are all taught about the infiltrative growth pattern, which is true frequently, but not always. But it's the vascular pattern that will help you think of fibromatosis. And of course, if you need a little hand holding with immunohistochemistry, beta-catenin can be your friend because it's not detected in the nuclei of gastrointestinal stromal tumors. So here's a nice example. I'm trying to show you these long, sweeping fascicles of myofibroblasts. And here's a itty bitty little vessel just popping right out at you. And here is a nice area of infiltrative growth. This fibromatosis extended into pancreatic parenchyma, and you could see it's even encircling, let's see, where's the pointer, encircling some of these pancreatic ducts. And this is the vascular pattern I'm talking about. Because the lesion is so pale, teeny tiny capillaries that have a little cuff of smooth muscle just really pop out at you at low magnification. And this pattern is your clue that the nuclei are pale in this lesion and that it's a benign lesion. And it's a clue that can be helpful with other mesenchymal tumors as well. So here are the vascular or the endothelial cell nuclei and some of the smooth muscle nuclei, and they're kind of darker than the lesional nuclei. And this is, of course, a very high magnification image of a fibromatosis, and they're myofibroblastic. So the cells will have amphiphilic cytoplasm, and some of them have this rather stellate contour, and each cell has a delicate nucleolus that's perfectly round, and you'll see it in many of the cells, depending on the plane of section. All right, so a beauty contest. On the left, we have the gastrointestinal stromal tumor, which is more cellular and centered in the muscularis propria, versus the fibromatosis that is less cellular, paler, centered in the mesentery, and even at this very low magnification, you could see all these little blood vessels popping out at you, whereas you don't really see that pattern in the gist on the left. This is a pitfall alert. It doesn't come up too often anymore. Early on, when the kit antibodies were first developed, it was a problem all the time because of too much antigen retrieval. It's no longer a common issue, but this is a 2020 case. So we still occasionally see it. Don't be the silly person who goes down the garden path. All right, so if you want to use beta-catenin to confirm a diagnosis, you're looking for it in the nucleus. It's not detected in GI stromal tumors. My former colleague, Vaishali Bhattacharya, actually wrote the first nice paper using this antibody. All right, so this is a perfect beta-catenin preparation. I've stuck a vessel in the center, so the nuclei are not staining in the smooth muscle. Now notice in the endothelial cells, the cytoplasm is staining, but not the nuclei, whereas a subset of the lesional cells show nuclear staining. Here are a couple more control vessels that only show endothelial cytoplasmic staining. You want to look for those. Now, if you have a rotten day in your immuno lab and the preparation is overstained, you can still find your little bitty blood vessels and use those as your internal control. This would be a positive because it's not staining the nuclei of the endothelial cells. Okay, let's look at another immunostaining pitfall that I hate. This happens to be a gastric Kaposi sarcoma. Of course, as you know, those can be really tricky to identify because Kaposi contains plasma cells, and gosh, so does the lamina propria of the GI tract. Now, oh goodness, I should move. Oh, I can't. Whoops. There are some hyaline globules here, which are a clue. And the lesion is more spindly than we would expect the patient's lamina propria to be. Here's also a teeny little pop of hemosiderin, so there are some clues to think of it. In the GI tract, you'll seldom see Kaposi with such beautiful hyaline globules as I've indicated in this image. Nowadays, if you're lucky, you can do an HHV8 or LAN1 or LAN immunostain. It stains the nuclei. Don't expect it to stain every nucleus. It's fine if it just stains some of them, and that will confirm your interpretation. A pitfall alert for Kaposi and angiosarcomas is that they both love to express CD117. So yours truly has been down this pitfall. This happens to be Kaposi expressing KIT or CD117, but this is an example of an angiosarcoma that I misdiagnosed based on a mucosal biopsy, and it was very clearly an angiosarcoma at the time of resection, but it was strongly KIT positive. Let's think a little bit about the emperor or empress of the muscularis propria, depending on your orientation. And that's GI stromal tumor. Of course, we've all heard of them, and I won't say too much. They can be spindly or epithelioid, and of course, they characteristically, but not invariably, express KIT or CD117, and they aren't just found in the main tubular GI tract. Of course, you can find them in the belly and occasionally in the bladder or gallbladder. Whoops, sorry. So they, in the US at least, they account for up to 10%, and I'm going to just lump them with sarcomas. They're usually in the muscularis propria, but this one happens to be in the submucosa, and the patient had a Whipple. There's some pancreas down here, but it's just such a pretty picture that I popped it in there. It's about 1% of gastrointestinal malignancy. It tends to be more common in men, and most patients are over 50. And the presentation, of course, is site-specific, depending on where the tumor is. Okay, so this is a very nice spindle cell gastrointestinal stromal tumor. You'd expect this to be in the small bowel, and you'll notice that the nuclei are very, very uniform, and that's your clue for GI stromal tumor. You will not see this uniformity if the patient instead has a leiomyosarcoma. In the stomach, of course, expect to see lots of paranuclear vacuoles, and notice the little cytoplasmic extensions here. They are very reminiscent of the appearance of smooth muscle, such that our forefathers regarded these as weird smooth muscle tumors that were a bit odd and arose in the GI tract. And of course, it wasn't until the late 1990s that the whole Cajal cell story came out. This is one with plenty of mitoses, but notice, so we would expect malignant behavior. We all know how to do the exercise of fake science counting mitoses. And if it's easy to find them, that's bad. Usually you'll either struggle to find them or find them easily. There are very few cases in the middle. So most of the time you don't have to be too compulsive about your counts. This is an epithelioid GI stromal tumor. Check out here, this is in the stomach. It was probably going to be an aggressive tumor because it's invaded the mucosa, but it's easy to see how somebody could get fooled and think this was a carcinoma. Here's a mitosis right here. We would expect this to be an aggressive tumor. Once in a while, GI stromal tumors can dedifferentiate, as in this case. Doesn't happen often, and it can either happen after treatment or de novo. If you're lucky enough to have this sort of thing with the low-grade component here before the dedifferentiated component, great. If you're not, and you do your kit workup for this, you may not even get staining, so they can be a bit tricky to deal with. So what are the associations with GI stromal tumor? Of course, they can be familial and multiple in patients with germline KIT mutations, typically exon 11, or germline PDGFRA mutations, so they get both GIST and inflammatory fibroid polyps. And then there are those that are associated with NF1, neurofibromatosis type 1. They lack KIT mutations, but you'll be able to diagnose them easily. They stain with KIT antibodies, and it has to do with an interaction between the NF1 gene product and the KIT gene product. And of course, there's Carney's triad, and that has epithelioid GI stromal tumor, paraganglioma, and pulmonary chondroma. So then that gets into the sort of sexy thing lately, and it's not actually so recent anymore, but that's the family of KIT wild type GISTs. All of them are easy to diagnose because they still express KIT and DOG1. We mentioned the NF1 associated ones, and then once in a while you'll see the SDH, succinate dehydrogenase deficient ones. They comprise probably less than 5% of GI stromal tumors. I think those figures are a little high because they're from studies from institutions that are referral centers, so they get all the weird stuff. Most of them arise in children. They're virtually always in the stomach, and your key is that they are epithelioid with plexiform growth. Curiously, they spread to lymph nodes, but they're indolent, and unfortunately, they don't respond well to imatinib. These are associated with the Carney triad. Now, of course, remember we just saw the Carney syndrome. So let's go back, I'm sorry, the Carney triad, GIST, paraganglioma, and chondroma. And these patients have methylation of these special succinate dehydrogenase genes, so it's not familial. On the other hand, Carney-Stratakis syndrome has GIST and paragangliomas, and these folks have germline mutations in the succinate dehydrogenase genes. So this is a nice succinate dehydrogenase deficient gastrointestinal stromal tumor, and the whole point, it's in the stomach, and it has this plexiform pattern. High magnification, it's very, very uniform, very epithelioid, and you just have to think of it and get your KIT stain, and then you're going down the right path. And this is super high magnification. Here's our internal control for size, the endothelial cells, and you can see the cells aren't too huge, and they're pretty monotonous. This one has spread to a lymph node. This was a patient who kept having repeat mini operations to get rid of the recurrences, but she perked along for many, many, many years, and the tumor did not kill her. This is an SDHB stain. Remember that succinate dehydrogenase is part of the Krebs cycle. The B, if you stain for the B, you'll pick up all the losses. And you can see that the muscularis propria shows cytoplasmic staining, but it's lost in the tumor cells. Once in a while, this type of GI stromal tumor does feature bizarre cells. And here is such an example. You'll notice that I'm not showing you mitoses there. In this case, there were essentially no mitoses, just this weird cytologic atypia. And it's just something you can occasionally see with these SDH deficient GI stromal tumors. And this is just that interface at very high magnification. Of course, probably many of you are aware of the fact that there's a subset of renal cell carcinomas that's also succinate dehydrogenase deficient. And of course, as we alluded to with the whole Carney business, you can see succinate dehydrogenase deficiency in paragangliomas, of course, of which pheochromocytoma is a classic in the adrenal. Okay, let's switch gears. Let's look at a gastric mass resected from an adult. And of course, the surgeon wanted KIT mutational analysis right as she took it out of the patient. So you already know it's not a GI stromal tumor. So here it is. And those of you who are onto these are noticing this, which is a lymphoid cuff around this lesion that's smack dab in the muscularis propria. At higher magnification, it has some nuclear atypia and a lot of lymphocytic and plasmacytic type cells in the tumor. Notice that there's variation in nuclear size in this lesion, and there's kind of degenerative cytologic atypia. Just to scare everybody, here's one area at super high magnification. And this is a gastrointestinal type schwannoma. Usually these are in the stomach and they are centered in the muscularis propria in almost 100% of cases. Once in a while, you'll see them in the esophagus or colon, and they're weird. In contrast to conventional soft tissue schwannomas, they almost always or always have these peripheral lymphoid cuffs. They don't usually have a decent fibrous capsule or vascular hyalinization, and very few of them show the degenerative changes of the type that I just showed you. Moreover, if you do molecular analysis, they lack NF2 alterations, which are very characteristic of conventional sporadic schwannomas from multiple sites. Just for fun, if you do a calretinin, most schwannomas have it, whereas these GI ones don't, although I don't think anybody does calretinin to evaluate schwannomas. So here's a beautiful example. Here's the patient's stomach, and then here's the spine. And then here's the resection. You can see the mucosa here, and you can see that this lesion is centered in the muscularis propria, just as we would have predicted on the imaging study. And of course, there's that thick lymphoid cuff in this gastric lesion. This actually isn't the one for which I showed you the imaging, but the lymphoid cuff is definitely your friend. And here's this one at higher magnification, sort of showing palisading. It's imperfect, but you know, we take what we can get. And there's plenty of inflammation in the background of these. Of course, if you're nervous, you can get yourself an S100 protein. I've become so jaded that I just do them on the H&E. If you don't like S100 protein, SOX10 works fine. So let's have another beauty contest. Here's our gastrointestinal stromal tumor with fairly uniform cellularity in the muscularis propria of the stomach, no lymphoid cuff. Here's the schwannoma centered in the muscularis propria, lymphoid cuff. Glomus tumors, they come up. I think still the largest series is from the former Armed Forces Institute of Pathology, and it showed a female predominance. And if something from the old AFIP showed a female predominance, that lesion has a female predominance. Remember that the AFIP used to serve the military. Most GI glomus tumors are in the stomach, and they tend to be right in the middle of the muscularis propria, and they can ulcerate on top so that the patients present with horrible melena. The vast majority behaves in a benign fashion. but occasional examples are lethal with metastases, and most observers have been unable to predict those that are going to do well and those that are not going to do well. But here's the important thing. They live in the muscularis propria, and here is one. It's richly vascular, but of course the knee-jerk response that we should all have to anything that is centered in the muscularis propria is to assume that it's a gastrointestinal stromal tumor. At high magnification, if you think of it, they look like glomus tumors such as you might see in the skin, with this exquisite basement membrane material surrounding each cell in a richly vascularized neoplasm. Notice that the cells are monotonous. And of course, at higher power, you might be fooled and think it's a neuroendocrine tumor. So quite some time ago, nearly 10 years ago, Christina Antonescu, who basically has found all these fusions in pretty much every possible tumor, noticed that these, oh dear, my screen just went dark. Let's say a prayer. Thank goodness. Notice that these things had a characteristic fusion. And of course, tumors with characteristic translocations and fusions do tend to have monotonous cytology. If you do immunostains, they do express smooth muscle actin and calponin, just like glomus cells, which are modified smooth muscle cells, but they don't have desmin expression. And if you want to really enjoy yourself, you can get yourself a basement membrane stain and see the beautiful net-like pattern for basement membrane proteins. Once in a while, you'll see CD34, but mercifully, you will not see KIT staining in these. The pitfall with these is that they love to express synaptophysin so that you're fooled into calling them neuroendocrine tumors, but luckily they lack chromogranin and keratin expression. So this is just smooth muscle actin in one, very, very pretty. And this is kind of for fun, but this is a collagen type 4, showing that net-like basement membrane reactivity. And here's our pitfall alert. This is synaptophysin in a glomus tumor. And just remember that if you get a frozen and you're thinking of calling it a net and it's in the muscularis propria, you're probably wrong. So remember that well-differentiated neuroendocrine or carcinoid tumors arise at the junction of the mucosa and submucosa. So you won't typically see them in the muscularis propria when they're small, and when they're large, you'll also see them up here. This is just from an endoscopic mucosal resection of a stomach one. So just another little beauty contest. Notice the location of the glomus tumor in the muscularis propria as opposed to the neuroendocrine tumor at the junction of the mucosa and submucosa. Let's hop up into the submucosa. And of course, the classic entity there that I hope all of you either already know how to recognize or now will know how to recognize is the inflammatory fibroid polyp. The name is a misnomer because we just didn't know then what we know now. They were first described by the Czech pathologist, and I won't try to pronounce his name. And he described 6 lesions, most of which were in the antrum. And the present term was created by Elston Hellwig at the former Armed Forces Institute of Pathology. He thought they were tumors of the stomach, but in fact, they can be anywhere in the GI tract. Okay, almost all of them are in the stomach. They account for about 1% of gastric polyps after you take out the fundic gland polyps. And they're nearly always, but not always, in adults. They're smooth submucosal lesions, and some of them ulcerate. And of course, the presentation has to do with the site. So this small bowel example with this beautiful submucosal based lesion coated by mucosa presented with intussusception, which is the case about half the time. This, on the other hand, was an antral lesion, and the patient presented with gastric outlet obstruction, so had to have a limited resection. Beautiful classic example in the small intestine. Here's muscularis propria, submucosa, and then this ginormous submucosal based lesion ulcerated at the top that had resulted in intussusception. Here's a more classic case. This was from a resection obviously these are benign, so this resection wasn't needed. The patient also had another lesion that did require resection. And then we have this beautiful inflammatory fibroid polyp. It has a lot of lymphoid aggregates. It's centered in the submucosa. Remember, our schwannoma has the lymphoid cuff, but it's in this muscularis propria. So nice example. And here's a beautiful example of a favorite feature of these, which is whirling around blood vessels. We can see that well here. And you can also kind of make out the massive backdrop of eosinophils. And notice there are a few cute little giant cells. They're very common in gastric inflammatory fibroid polyps. And here's a really lovely example of this whirling around blood vessels. Some people have called this onion skinning or an onion skin pattern. Okay, these were named inflammatory fibroid polyp because our forefathers thought they were reactive, but now we know, of course, that quite a large percentage of them has mutations in PDGFRA, just like some gastrointestinal stromal tumors, but these are always benign. If you do immunohistochemistry, the immunostain that is characteristically positive, but not 100% of the time, is CD34, and they are kind enough not to stain with kit or dog. So here's a nice example of that. So I'm going to finish off some mucosal nerve sheath tumors, and these are something that we see frequently because nowadays people get a lot of colonoscopy. In the United States, screening colonoscopy for people of average risk for the development of colon cancer started to be paid for by the various insuring bodies. And so since then, we're starting to see all sorts of cute little polyps, and we have to deal with them. And some of them are benign mucosal nerve sheath tumors. So let's look at a cecal polyp found at the time of screening colonoscopy. We've reached the mucosa, and here it is. And it is very cute. So I kind of lied. There's a little bit of it in the mucosa, but I have to say there's a bunch of it in the submucosa. And here it is. Hopefully many of you are recognizing it. And here's more of it. And you'll see that it's mineralized. And this is a colon granular cell tumor. Of course, most GI granular cell tumors arise in the esophagus or anus because that's where there's squamous mucosa. Of course, throughout the whole body, the skin is the most common location for a granular cell tumor, but occasionally it's found in the colon. It tends to be in the right colon, and it can have those degenerative nuclear changes or mineralization, and it can recur because it's hard for the endoscopist to totally remove it. To date, I have not found any convincing reports of malignant examples of colonic granular cell tumor. There are some that aren't convincing, but there are a few convincing reports of malignant granular cell tumors arising in the esophagus. So this is, of course, the resident exam question or the whatever certification exam question. This is an esophageal or it could be anal, but I think this one was esophageal granular cell tumor. Here it is. And of course, it's created this dramatic pseudoepitheliomatous hyperplasia. And epithelioma was the old word for carcinoma. So you could also call it pseudocarcinomatous hyperplasia. A clue that this is fake is that it's very easy to see the intercellular bridges in this hyperplastic stuff. And you usually can't see them so well in carcinomas. But of course, if you spot the granular cell tumor, that's your clue to back off. And of course, if you want to stain, you can do S100 protein or SOX10 to confirm your interpretation. These also stain with inhibin, but I don't think there's much of a reason to do it. Something you'll see not infrequently is a lesion that Jason Hornick and his colleague, Dr. Gibson, I think her name is Joanna. Please, if you're Dr. Gibson, don't smack me. And that's Schwann cell hamartoma. And they're not exactly hamartomas, but I believe the authors use this terminology to separate them from mucosal neuromas, which can be quite clinically significant. So this is an example of such a case. You can see that the lesion proliferates between the colonic crypts. It's very superficial, and you get this kind of suggestion of palisading. Notice that there's this thick, coarse fibrillary collagen. You might find yourself thinking about a smooth muscle tumor, but the nuclei have pointy ends instead of blunt ends. Here's another field showing the same thing. And they're generally incidental, sporadic lesions of absolutely no consequence. I will tell you as an aside, once in a while, they're associated with the Cowden syndrome or the P10 hamartoma syndrome. But if you just see one, it's probably incidental. Here's super high magnification. You can see that they tend to have intranuclear inclusions, just like several other Schwannomas tumors. And then you can see this sort of dense fibrillary cytoplasm that's pretty abundant. And of course, these do stain with S100 protein if you want a confirmation. On the other hand, the brother of these is this so-called perineurioma or perineurial proliferation. Some people don't think that they're neoplasms. And these were originally called benign fibroblastic polyps of the colon. They basically are found in folks in the colonoscopy years. They are intimately admixed with serrated polyps in some cases, and they're in the lamina propria and go between the glands, just like the Schwannomas hamartoma. If you do immunostains, they really don't stain with much of anything, but if you're lucky enough to have Claudin-1, the classic perineurial marker, they do stain with it, and you can usually get some expression with epithelial membrane antigen. So folks tend to call them perineurioma or perineurial proliferations. They're benign and incidental. So here's such an example. You can see it's associated with a serrated polyp. I think this one's probably a sessile serrated adenoma rather than a hyperplastic polyp, but here's the lesion in question for the moment. This perineurial cell proliferation. And I have an arrow indicating these delicate cytoplasmic processes that tend to hang off of each cell. In between, there's really not much going on. So you look for these delicate filamentous extensions from individual tumor cells. Here's a nice example showing the long cytoplasmic processes. Here's one, here's a nice one. Here are a few of them hanging out in the background in these perineurial lesions that infiltrate between the colonic glands. So here's a very dramatic example. These remind me of spermatozoa because I'm a dirty old lady, and I'm sure this picture will also make other people think of it, maybe not everyone. All right, so this is about as much epithelial membrane antigen staining you're going to get with these. This one happened to be in the stomach, but they're super rare in the stomach. On the other hand, you might see much more dramatic staining if you have GLUT1, but of course, GLUT1 is a pretty non-specific stain, but obviously it stains erythrocytes. That's its whole point. So actually, in my opinion, you can diagnose both of these things on hematoxylin and eosin just by paying attention to cytologic detail, the perineurioma with the long cytoplasmic processes on the left and the Schwann cell hamartoma with the dense cytoplasm is on the right. So what's the one you have to worry about? Well, the little guys that we just looked at, it doesn't matter if you mix them up, they're benign and incidental. Very rarely the Schwann cell hamartoma is associated with Cowden syndrome or P10 hamartoma syndrome. You don't really need to worry that there's extension from a gastrointestinal stromal tumor. If that's the case, the lesion will be quite cellular. The thing you want to pick out is the mucosal neuroma of MEN2B. If you're like me, you can't remember the MENs and have to look them up. Multiple endocrine neoplasia 2B consists of medullary thyroid cancer, pheochromocytoma / paraganglioma, and neuromas and ganglioneuromas, often in the intestines. So this is the key feature of these mucosal neuromas. This is an epithelial membrane antigen stain. So you have the little lesion, but it has a cuff of perineurial tissue around it. Here's a very nice example of a mucosal neuroma that arose. Actually, this was in the buccal mucosa, not in the GI tract. But again, it's like you sort of wonder if it's a plexiform neurofibroma, but no, it's not great for that. This is your mucosal neuroma. Here it is at higher magnification. So there's a cuff of perineurium and then this neuromatous proliferation inside. So this is a colon biopsy, and I nearly missed this finding, gulp. But after you look for a sec, you'll see this little guy here and this little guy here. Here's another area or one of those at higher magnification. So I became very concerned that this patient could have a mucosal neuroma. And here's US100 protein, and it's showing us that indeed there's nerve sheath differentiation in some of the cells within these little nodules. But here's epithelial membrane antigen, which shows a perineural cuff around one of them. So unfortunately, I don't have the full outcome on this patient and whether there was confirmation that the patient had MEN2B, but certainly this was a sign to investigate the patient further. So we've covered a lot of stuff. Do remember thinking about the layers. Most of the lesions are just H&E diagnoses, but of course we all need a little hand holding sometimes, just like I did in that mucosal neuroma that I just showed you. So I've moved from Baltimore, Maryland, but this is an actual street in Baltimore, Maryland, where I used to live. Thank you very much. So I am going to stop sharing, and now you can see Dr. Manan and me.
Thank you so much, Dr. Montgomery, for this great talk covering so many different mesenchymal lesions in the GI tract. We have a few questions from our viewers. So one question which has come up is, do you report perineurioma as well as sessile serrated adenoma in the final report?
I do mention the perineurioma, but I just do a little parenthesis and say benign incidental finding, and nobody seems to mind.
Okay, thank you. So there's another question. So the question is about epithelial myofibroblastic sarcoma. So which other immunomarkers or molecular tests can we use to confirm the diagnosis of epithelioid myofibroblastic sarcoma, especially in small biopsies? Do you have any suggestion?
Basically, you have to think of it and get an ALK stain. Obviously, you can send it for molecular confirmation, but you just have to think of it. And you'll think of it when you have an ugly epithelioid lesion. And if I see an ugly epithelioid lesion like that, I get myself a keratin, I get myself my favorite melanoma marker, and I get myself a whole bunch of unstains so that I don't run out of tissue before I have a diagnosis. So don't shotgun up front. Don't do every stain you can think of. And then if the first two are negative, the melanoma marker and the keratin, then it's time to get yourself a Desmond for the next decision tree. And that could put you to get the ALK. And nowadays, actually, it's not a bad idea to get the ALK anyway, but really you just have to have it in your list and get the ALK.
Right. Here's another question. So the question is that should beta-catenin be always positive in fibromatosis?
Should beta-catenin be always positive? The answer is yes and no. My experience is if you have a great big piece of tissue, you can always find some nuclear staining. But on a needle biopsy, you may not get the nuclear staining. So if everything is perfect, and nowadays, of course, we have MUC4 to exclude low-grade fibromyxoid sarcoma. If you've done that homework and your beta-catenin is negative and it looks like a fibromatosis, you're probably just fine signing it out as such.
So here is our next question. So do you routinely perform immunostains to confirm granular cell tumor and leiomyomas with classic morphology in the esophagus?
No.
Okay, okay. So in that situation, so you will just rely on H&E alone, right?
Yes, and in fact, if you get an esophageal leiomyoma, and I know you know this, Dr. Manon, and you're dumb enough to do a kit, there are sometimes be quite a few Cajal cells in there that just proliferate with the lesion, or or overgrown or something, and then you end up having to get the darn actin or desmin anyway. So no, I just sign them out on the H&E. But there are a couple papers about if you get a kit in esophageal leiomyomas, you'll often have all these little entrapped cells and then find yourself more confused.
Right. You showed this nice example of granular cell tumor in colon, and you also showed an example of granular cell tumor with the classic pseudoepitheliomatous hyperplasia. And so what is your suggestion to our viewers, like who are practicing in different parts of the world, that what is the clue that they should look for? Because there can always be a confusion about, are they missing a squamous cell carcinoma on top? What is
I
your
think
suggestion?
probably the best, obviously, if you see the granular cell tumor, that's good. But for me, if you look at the cytologic features of the pseudoepitheliomatous hyperplasia, they'll match the stuff on the surface that doesn't look that bad. And you'll see very edematous intercellular bridges. Can squamous cell carcinomas have edematous intercellular bridges? Yes, but they are usually not a very prominent feature. So I think that's your best helper for fake.
Right. So thank you, Dr. Montgomery. And another one of our colleagues wants to know that what is your experience when you differentiate benign versus malignant mesenchymal lesions when there is an associated ulcer?
Oh, be careful. Be careful if you have an ulcer and you see atypical spindle cells that are often just pseudosarcomatous cells, and do not commit if there's an ulcer and you're not sure.
Right. Yeah. And so there's another question from one of our viewers is, so regarding perineuriomas and Schwann cell hamartomas that you have just illustrated so nicely, would you suggest one immunostain at least that can be helpful, or it's not important? Like somebody might miss to call it one way or the other.
It doesn't make any difference. I guess if you want to get yourself a stain, get an S100 and look for positive versus negative. But these are just incidental lesions, so you don't need to chew your nails if you're not sure, and you don't have access to a lot of immunostains.
Right, right. And so there is another question from one of the viewers who is mentioning that probably there was a paper, I think, from your group a few years back regarding Pacinian corpuscle-like lesions in the GI tract. Do you want to comment on those lesions?
Do I what?
Do you want to say something about those lesions? Like,
Oh, they're super rare, but they're really cute. I'm amazed that somebody even read that paper. They're just incidental little things, and you usually see them at the gastroesophageal junctional mucosa, and they look just like the tactoid bodies or Wagner-Meissner bodies in diffuse neurofibromas, but they're just itty-bitty things.
you're right, right. So, so one more question
Rifat, were
regarding.
you on that paper? I can't remember.
No, 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 no. I'm
Oh, oh no, your famous one was the outlet patch.
right, right. So there is another question. So, in IMTs, do you recommend to perform immunostain for ALK1 or ALK D5F3 or both?
I usually just do ALK1, but if take all the help you can get, because obviously about 40% of the time it won't be positive.
Right. Someone is also asking about the, positive staining for cytokeratin in IMTs. And when IMT is positive and ALK is negative, and they're still thinking of, IMT, so should they go for molecular? What is your suggestion?
So the colleague is saying ALK is negative, there's some keratin staining, and it looks like an IMT.
Right.
So you know what? It depends on the resources in your country, but generally in that situation, you sign it out presumptively as ALK negative IMT, send it for sequencing and see if it pops up in NTRK or a ROS. And some people have the ROS1 antibodies or something else targetable. Of course, if it seems to be completely excised and isn't bothering anybody, they can probably just follow the patient. So it all depends on your resources. Because remember, not everybody with an IMT needs targeted therapy. And in fact, many patients don't. They have their IMT out and they're just fine.
Right. So here's one question regarding cyst. That when there are two questions. One I would read to you first. If you have a cyst, like what is your experience if there is a strong morphologic suspicion that it is a cyst in classic location, but both dog1 and c-kit is negative, and you don't have research to do molecular?
Show your colleagues. It's probably something else because those two stains pick up almost all of them. And, you know, there are a lot of more recently described tumors like these GLE1 rearranged tumors and all this other stuff that very few people have the resources to address. And I think you need to send it to a consultant or show it to your colleagues because it's very unusual to have it just with both of those things negative.
Right. And staying on this, there is another question that if the cyst was already treated, and like, I mean, what are the clues in morphology for our colleagues that you can suggest that it is already treated, and what stains should work? Or
that is a great question. Treated just look like this sclerotic mess, and you scratch your head, and sometimes you'll get a liver biopsy, and nobody's told you that the patient had a gist. And then you get this sclerotic thing. But if you put in enough sections, you'll often find just a few areas of residual tissue and then choose those blocks and get a kit. But, oh, those are super sneaky and super hard. So I think the person who posed the question posed the most important thing. You've got to think of it. So the main thing is to think of it if you see some strange sclerotic lesion.
Right, right. And regarding treated cyst, is there any recommendation that you have to report about a percentage of viable tumor and things like that? And or
what kind of tumor?
So if the cyst is treated, as far as reporting is concerned, so is there any suggestion that you report on percentage of viable cells that are present on the tumor and things like that?
You know what? I don't know if there are published standards for that, and there may be that I missed. I do try to give them an estimate of the percentage necrosis or sclerosis. It probably doesn't really matter, but it will make the oncologists feel good to go back to the patient and say, oh, well, you know, our colleague said that 90% of your tumor has been knocked out by the treatment.
Right. So staying on this, I have a question for you. And so recently we had a case, this patient had epithelioid cyst, which was HD-ASB deficient. And the recent case had like cyst all over, like the patient has been on treatment for some time, and I don't know exactly what they have treated with, but there are mesenteric nodules, there are nodules here and there which are not related, actually connected to the what is a bowel wall. So what's your experience with those type of things? Like, is it common to have like cyst which has metastasized to all over different parts?
I don't know the percentage that does that, and that is knowable. There are some good long-term studies, but yes, it is common to have little globs all over the place. And I know in my somewhat limited experience, the surgeons just go in and take them out. They don't respond to the medicine, but they don't grow very fast. And then they keep monitoring with imaging, and then they go in and take them out again. So that's probably what will end up happening with your patient.
Right. Right. Thank you. I think these are the questions that I could find online, and thanks to all of our viewers for joining today, and special thanks to Dr. Montgomery for joining us for this excellent and very illustrative session. And all our viewers are actually expressing thanks on Facebook and YouTube for your illustrative and very informative session. And thanks to our viewers. And Dr. Montgomery, you would be happy to know that we had close to 250 or so viewers from so many different parts of the world. And the viewers joined from Pakistan, Nicaragua, Ukraine, Zambia, Tanzania, Dominican Republic, Germany, Colombia, to name a few. And thanks a lot for our viewers for joining us today. And if you like our lectures, so don't forget to subscribe to our channel, that is Pathcast. And also we have a Facebook page. You can follow that, and you can visit our website where all the lectures are arranged. And you can also access Dr. Montgomery's previous lectures that's presented on Pathcast. And our next top lecture is coming up, that is on July 7th, so which would be on fetal placental malperfusions. And our speaker is from Case Western University. So hope to see you at that time. And thank you again, Dr. Montgomery, for this excellent talk.
Dr. Manan, you provide a wonderful service to colleagues all around the world, and you're the one who should be applauded. So it's been a pleasure to join the group.
Thank you so much, Dr. Montgomery. Always a pleasure.